Welcome guys to another series today on the bones of the upper limb. We have talked about the clavicle in our last video, where we talked about the clavicle is connected to the scapula at the lateral side and connected to the manubrium of the sternum at the medial side. So go watch my video on the clavicle of the upper limb. So we're talking about the scapula. Just like the clavicle, we say the clavicle is otherwise called the collarbone. Here the scapula is otherwise called the shoulder blade. So know them specifically for your exam. So now in the scapula, now what happened? It's very large, so you can see it is very broad and large. It is flattened and it's just like a triangle shaped bone. Again, large, flattened, and a triangular what shaped bone located in the upper aspect. Now follow it, the upper aspect in the posterolateral part of the thorax. Don't forget, it is large, flattened, and it has a shape of a triangular bone located in the upper posterolateral aspect of the thorax, and it is from the second rib to the seventh rib. So it is resting on our rib in the posterolateral aspect of our back. So if you go to your back, you can palpate your scapula at your back and the upper posterolateral at the lateral region. Now it is coming from the second rib, so where it is attaching to the rib, it runs from the second rib to the seventh rib. Don't forget. So since we know this about the scapula, now we can see that it is mobile, so you can palpate and move your scapula. Sometimes in physiotherapy they call it what we call scapular mobilization. You can mobilize your scapula for somebody that has not been moving for a long time, so you can mobilize it so that it will not get what contracture, it will not be so stiff. So you can, it's mobile, and it's made up of what? A body and three process. It is made up of a body and three process. Now in the three process is the spinous process, you have the acromion process, and you have the coracoid process. We are taking it one step at a time. One, it is mobile. It is mobile, which means you can move it, and during rotation and the movement of the humerus around the scapula, it is very mobile. So sometimes you can have to retract it and move it all around so that there will be no contraction for patients that cannot move their upper limb, maybe due to any underlying condition. So like I say, in the process you have spinous process, you have the acromion process, and you have the coracoid process. Now under the body, now the body can be split into so many. You have the surface, you have the border, and you have the angle. So follow me, you can use your atlas or you can use your textbook. Just follow me and listen to me, understand it, use the diagram that I'm showing you now so that you understand it. So you have the surface. In the surface you have the costal or anterior surface, that part of the scapula that is resting on the rib, that is the costal or anterior surface. Now you have the dorsal or the posterior surface. Now you can know the dorsal or posterior surface by the spinous process, like I said before. Now you now have the border. In the border you have the superior border, you have the lateral border, and you have the medial border. So you just watch it, you see it on your screen, it's already labeled. So I'm giving you the picture so that you understand it, because the goal is for you to understand the bones so that we enter into the muscle. So you just follow it one by one like that. Now the last one is under the angle. So the angle is just the part of the bone that is pointy. So you have the superior angle, you see the superior angle is more pointy, you have the inferior angle, and you have the lateral angle. So we have divided the process and the body. So it's very, very important. So first of all, if you are looking at the surface now under the body, now you should look at the surface. So how can you know that this is the anterior part, and how can you know this is the posterior part of the scapula? The anterior part has a depression, so it has a depression. Are you getting it now? And that depression is called the subscapular fossa. It is called the subscapular fossa. So how will you know the posterior? So you are seeing it on your screen. This is the anterior part of the scapula, which you call the subscapular fossa. It's just like a depression, and now it has what you call an oblique ridge for the attachment of the subscapularis muscle. So you see like about 5 oblique ridges, before 4 to 5 oblique ridges, which marks the point where the subscapularis muscle is originating from. Now how can you know the posterior? The posterior, you know it by a spinous process, a long spinous process, which is at the level about C7 to T1. So it's coming out at C7 to T1 by landmark, and the spinous process continues to form the acromion. So it is coming as the spinous process, and it is demarcating the posterior or dorsal part of the scapula. Now that it is continuous, and when the spinous process continues, it continues as the acromion process. You can see it. I'm just giving you the pictures so that you can envision it, because when I will be talking about the muscles, I will be needing you to follow me. I want you to know the muscles of my heart. So important. So in the anterior, you know it as the subscapular what fossa. In the posterior, you know it as the what spinous process. So if they give you the scapula, how you will know is that there's a depression in the front and there's a spinous process at the back. Now, in the posterior dorsal part now, the spinous process, the posterior part now, if you are holding it posteriorly now, the spinous process is dividing the posterior part into two. Above the spine is called the supraspinous fossa. Below the spine is called the infraspinous fossa. Don't forget. Above the spine is supraspinous. Below the spine is infraspinous. Why in front is what? The subscapular what? Fossa. Above the spine, mark the origination of what? Your supraspinatus what? Muscle. So your supraspinatus is originating from the supraspinous fossa and it's inserting on the what? Greater tubercle. While infraspinous fossa mark the origination for infraspinatus. So when you watch my muscle of the shoulder region, you know, because the supraspinatus, infraspinatus and subscapularis together with the teres minor marks the rotator cuff what? Muscle, which you have done in our muscles of the upper limb. So you can, after you have watched the bone, you can go watch the muscles of the upper limb. Now, since we have known the anterior and we have known the posterior, so what about the borders now? So we have a superior border, we have a medial border, and we have a lateral border. So how can you know the medial border? How can you know the lateral border? In the costal part now, which is the front part, I told you the costal on the anterior part, that is where the subscapular fossa is. In the medial border of the anterior surface or the costal surface, now what can you see in the medial border, which is related towards your vertebrae, because the medial border is towards the vertebrae. So in the costal part, which is in the medial border of the costal part, you can see the serratus what? Anterior. So the serratus anterior is inserting on the anterior medial border of the what? Scapula. The serratus anterior originating from the what? The second to the about the 8th digitation of the rib, and starting on the anterior medial border of the what? Scapula. Now if you now look at the posterior axis, now the posterior part of that same medial border, but not anterior, in the posterior part of the medial border, now you can see the arrangement of the levator scapulae. So the levator scapulae is originating in the upper part before you see the spinous process. You are seeing it on your screen in the upper part before you see the spinous process. Now the rhomboid minor is originating at the level of the spinous process, which is about C7 to T1, while the levator scapulae is originating from about C1 to C4. So you go watch the muscles of the deep compartment of the shoulder joint. No, we have intrinsic and we have extrinsic. We have intrinsic and we have extrinsic. Intrinsic is you have the sit down there muscle, which is the sit muscle, and you have this down there, which is the deltoid and the teres major. So you go watch it. It's just a mnemonic. Sits down there. Sits for rotator cuff muscle, down for deltoid, there for teres major. And in the extrinsic, you have the superficial extrinsic and you have the deep extrinsic. The deep extrinsic is the levator scapulae, rhomboid major and minor. What they do is that they retract the scapula. So in the posterior axis of the medial border, you can see the levator scapulae from C1 to C4, which is the origination. Now this origination, you can see it above the spinous process in the back, while the rhomboid minor is C7 to T1 in the angle of the spinous process, while your rhomboid major is below T1, which is from T2 to about T5. This is where you are seeing the rhomboid major now. So now you can call it also the rhomboideus major. So I used to call it the rhomboid major. So this is in the medial border. The medial border is related to the vertebrae. So you can see it in either side of the vertebrae. So that's why they work majorly. They internal rotate. So those that are located towards that place, they internal rotate. Now in the lateral border, now what can you see in the lateral border? First of all, in the lateral border, muscles that are located posterior lateral, you can see muscles that are located in posterior lateral. So you can see when you go up now, you can see the what? The teres minor muscle. The teres minor muscle, you can see it at that particular point in the medial border, but in the posterior axis, because no muscle is originating in the what? Anterior axis, but you can see a muscle locating but you can see a muscle originating in the lateral border but in the posterior axis. So I'll call it posterior lateral side. So you can see it on your screen. The teres minor originated above in the lateral border but above, while the teres major is originating below, but both of them are originating in the lateral border of the scapula. But the only thing, one thing you have to understand, that the teres minor is divided by the what circumflex scapular artery. Don't forget the circumflex scapular artery. So you know that the circumflex scapular artery is also passes what we call the upper triangular space. So go watch my video on the triangular spaces. So there's what we call, there's upper triangular space and there's what we call the triangular interval. Triangular space upper, and you have the lower triangular space, or you can also call the lower triangular space, you can call it the triangular interval. But the circumflex scapular artery, which is demarcating the T minor, passes through the upper triangular space, don't forget, and it forms the anastomosis around the word scapula. Don't forget. In the anterior medial border, you can see the serratus anterior. In the posterior medial border, you can see the levator scapulae, rhomboid minor and rhomboid major. While in the posterior lateral now, you can see the teres major and teres what? Minor. So hope you are getting it one by one. You are seeing it on your screen. I like showing people the physical bone so that you can follow me while we are talking about it. So you have the medial border, you have the lateral border, and you have the superior border. Now, in the superior border, you can see what we call the inferior belly of omohyoid. In the superior border, the inferior belly of the omohyoid is originating from there. So the inferior belly of omohyoid starts from the superior border of the scapula and the ascent up. It ascends up and forms a what we call an aponeurosis, or it forms a part which continues with the superior border attaching to the head. Are you getting now? Don't forget. So you have the omohyoid. You have your inferior belly, which begins from the scapula and continues as the superior belly to attach to the hyoid bone. So we call them the infrahyoid muscle. We call them the infrahyoid muscle. Don't forget. So the omohyoid has the superior belly and an inferior belly. Inferior belly is originating from the superior border and it continues as the superior belly attaching to the what? Hyoid bone, and they are called the infrahyoid muscle. So when you read your head and neck, maybe when it gets to your upper part, when you start reading your head and neck and neuroanatomy, it will be much more easier for you to isolate it. And you also have your suprascapular ligament. So your suprascapular ligament also bridges the what? Suprascapular notch. That's what we call the suprascapular notch now. A suprascapular notch is where your suprascapular ligament bridges for the passage of the suprascapular nerve. Hope you are getting it. So it is very, very important. So I'm showing you all the pictures for you to get it. So we have the suprascapular nerve. We have the suprascapular nerve. The suprascapular nerve is a very, very important nerve which is from the brachial plexus. So it comes from the C5, C6, which is the upper trunk of the brachial plexus. So it passes through the suprascapular notch. So first of all, it is a notch, but when the ligament transverse through the notch, it converts to a what? Foramen. So without the suprascapular ligament or the transverse suprascapular ligament, you cannot have a suprascapular foramen. So before it is called a notch, but when the ligament crosses through that notch, it converts it to a suprascapular what? Foramen, and that is where the suprascapular nerve passes through. Is from the brachial plexus, C5, C6. Now this is for the upper border. Now the next one we're talking about is the what? Angles. The angles. Now we have the superior angle, which you'll be seeing. Now you have the inferior angle and you have the lateral angle. But you can also see that there's also an angle called the acromion angle, because when the acromion is being formed as a continuation of the spinous process, you can see, look at the spinous process moving up and continues. Are you getting that? The spinous process is moving up, continues as the acromion process. So you can also see an angle there called the acromion angle, which is forming just like a triangular shape, a pointing out aspect. So we can add it as part of the angle, but naturally there is superior angle, inferior angle, and lateral angle. Very important. In the lateral angle, you can see the word glenoid cavity. Don't forget. So hope you are following. You can see the glenoid cavity. So this is just an overview talking about everything about the bone. So you can see the glenoid cavity. The glenoid cavity is where the head of the humerus enter to form the glenohumeral joint, or you call it the shoulder joint. So the glenohumeral joint is the combination or the articulation of the head of the humerus and the glenoid cavity of the scapula. So when the head of the humerus enters, it gets deepened by a fibrocartilaginous ring called the what? The glenoid lambrium. So the glenoid lambrium causes the deepening of the hemispherical head of the humerus to form the glenohumeral joint. Don't forget, this is at the lateral angle. Below the lateral angle, you see the long head of the tricep. That's where the long head of the triceps is originating from. While above, you see the long head of the bicep. That's where this is originating from. So we have supraglenoid tubercle. That is where the long head of the bicep is originating from, and infraglenoid tubercle. That is where the long head of the tricep is originating from at the lateral angle. You are seeing it. Supraglenoid above the glenoid cavity, infraglenoid below the glenoid what cavity. So long head up, long head down, but long head of bicep up, long head of what tricep down. Don't forget, it's very very important. In the inferior angle, that is where the latissimus dorsal is what inserting in. So the blue is for insertion, while the red is for origination. The blue is for insertion, the red is for the origination. The rhomboid people are blue. That's why you see that they are coming from the, which is for the levator scapulae, from C1 to C4 inserting on this part, while the rhomboid minor coming from C7 to T1 inserting on that part, while rhomboid major is coming from T2 to T5 inserting on that part. While latissimus dorsi is also originating and is inserting on the inferior angle. Don't forget, I'm giving you so many landmarks. Please, is very very important. Another thing you have to know here is that the deltoid also is coming, which is the acromion part of the deltoid. So we have the anterior part, you have the acromion part, and you have the posterior part. The acromion part of the deltoid is originating from the acromion process of the scapula, while the anterior part is coming from the anterior surface of the what clavicle. Don't forget. Also the trapezius here too is also inserting here. So the trapezius is also coming from many parts, which I've also discussed in my muscles of the what shoulder region. It's coming from the external occipital protuberance, noctural ligament, down to your spinous process of C3, down to your T1 to T12. So part of it is inserting on the what anterior part of the what spinous process of the what scapula. Very very important. So blue is for insertion, red is for origination. So deltoid is originating, which makes it red. Blue is for insertion, which makes trapezius inserting there. So very very important. Now in the coracoid process, now because we have done the spinous process, the spinous process is an important demarcation. The acromion process here, what is the acromion process doing? The acromion process here of the scapula is attaching or articulating with the acromion end of the clavicle to form an acromioclavicular joint. Don't forget. So the acromioclavicular joint is the acromion or lateral end of the clavicle with the acromion process of the what scapula to form an acromioclavicular joint. Don't forget. So all these things are very very important. They are very very important for you. Now the coracoid process, you also see the coracoid process is a part that is what projecting. It is projecting forward. So if you are holding the scapula now, you see the coracoid process projecting forward. So in the coracoid process now, what are the important things that attaches to the coracoid process? So you can palpate the coracoid process under the what clavicle. So it's just an important landmark where surgeons use so that they will not damage somewhat vital or neurovascular structures. Now the coracoid process, you can see it under your clavicle. Don't forget, 2.5 centimeter below the clavicle. That's where you can palpate it. So it's very very important for your what exams. Now the coracoid process is also important, like I said, because so many things are attaching there. The tip of the coracoid process allow for the attachment of two things: the short head of bicep brachii, don't forget, the short head of bicep brachii, and the coracobrachialis. That is the short head. The tip of the coracoid process is for the what origination of two things: coracobrachialis But in the coracobrachialis is for the attachment and also the bicep brachii. Why the pectoralis minor is inserted in the medial border of the coracoid process, while the coracoacromial ligament is attaching in the lateral part of the coracoid process. Don't forget. So the medial border of the coracoid process is for the insertion of the pectoralis minor, while the lateral side of the coracoid process is for the insertion of the coracoacromial ligament. Not insertion, but the attachment, because it's coming from the acromion part and it's attaching to the coracoid process or in the lateral border. Why also, don't forget, there's also an origination, there's also an attachment here too, because the coracoclavicular ligament, like I said in my clavicular video, the coracoclavicular ligament is coming from where? The coronoid part and the trapezoid line of the clavicle, in the lateral end of the clavicle. Again, you see a bulging out part of the clavicle at the lateral end called the coronoid part. You call the conoid part. Why? You also see a breaking line, you see there. So if you are holding your clavicle, you palpate it, there's a breaking line there, you call it the trapezoid line or ridge. So the coracoclavicular ligament is originating from there. So when it originates from there, it is inserting on the coracoid process. Don't forget to. So why the tip is for the origination of short head of biceps and also coracobrachialis. Don't forget. So hope it's making sense to you and you are understanding everything. So you have seen everything, you have seen the pictures. It's very, very easy. Superior angle, inferior angle, latissimus dorsi inserting in the inferior angle, then your head of your humerus is entering the lateral angle, then your superior angle do not really have what is attaching to the superior angle. But in the superior border, you can see the suprascapular ligament is converting the notch into a suprascapular foramen, so that the suprascapular vessels and nerves can transverse through. So you can know the front by the subscapular fossa, and you can know the back by the spinous process. Spinous process is divided into the supraspinous fossa and infraspinous fossa. Hope it's making sense to you. It's so important and it's so simple. So I have dissected everything already, so there's nothing you have not heard and I've said, because I've discussed everything about the scapula. Very, very easy. The next is the ossification of the scapula. The ossification of the scapula is by what we call endochondral ossification. Now for the scapula, how many centers? You have 8 centers here for the scapula. 8 centers, but only one primary center. Why for clavicle you have 2 primary centers? So it's the only bone that has 2 primary center. But for the scapula, it has 8 centers, 1 primary and 7 secondary. Don't forget. 1 primary center is at the body, while 7 secondary center is scattered. You have 2 secondary center in the coracoid process, you have 2 secondary center in the acromion process, and 1 center scattered between the medial border, inferior angle, and the lower rim of the glenoid cavity. So when is the ossification time? Remember, the clavicle ossifies, which is the primary center of the clavicle, ossifies in the 5th to 6th week. Ossifies in the 5th to 6th week, while the primary center of the scapula ossifies in the 8th week. While some literature will tell you it's the 7th week, but don't forget it's in the 8th week. Why the secondary center ossifies in the 15th year after the womb. So it can be the 15th year or it can be the 20th year. Don't forget. So I'm always comparing it with the clavicle for you to understand. So go watch my video on the clavicle for you to understand very well. So sometimes in the clinical scenario, so you can have the fracture of the scapula. For my clinical scenario, you can have what we call the fracture of the scapula. So anytime there's fracture of the scapula, remember there's what we call scapular anastomosis. You have blood vessels from the subclavian artery and the axillary artery form an anastomosis around the scapula. So when you fracture the scapula, you can damage those blood vessels, which can cause avascular necrosis. So fracture of the scapula is usually transverse. So it is transverse usually at the body, lower part of the spinous process. That's where you have it. So I hope it all made sense to you and you have understood everything I've talked about in the anatomy of the word scapula. So we have talked about everything, starting from the positioning. The positioning is knowing the front and knowing the back, and knowing that the landmarks, which is coming from the second intercostal space to about the seventh intercostal space, which is the second rib to the about the seventh rib. We have talked about so many things, so you can go throughout the video, use your atlas, follow my video every time, like, subscribe and share it to all medical students because it will be helpful to you. So I'll be seeing you in my next class and my next video, which is the anatomy of the humerus. Bye bye.